Thank you very much, and thank you for the invitation. I have no conflict of interest to disclose. I just have to thank McCabe because they have provided me with a set of EDI catheters to conduct the research study that I will present you, and they lend me a servo hire. Bronchiolitis, as you probably all know, even if most of you are not pediatricians, but you are all aware that this is the most frequent pediatric respiratory disease, and this is a real public health problem because it's thousands of kids are hospitalized every year for this disease, and 10 to 16% of these children are hospitalized in pediatric intensive care units. I will speak about NAVA, but it's important to realize that the first step, the first tier therapy in bronchiolitis is nasal CPAP. It has been long validated. There's no really good large randomized controlled study that have shown the superiority of this mode, but the historical studies that I show you here have confirmed that with the implementation of non-invasive ventilation, and especially nasal CPAP in bronchiolitis, there has been a dramatic decrease in the intubation rate. So this is relatively good evidence that CPAP is great. However, there are still some aspects that NAVA could help in this population. How? First, it's important to realize that 10 to 35% of patients will fail a CPAP trial or have to be intubated before a CPAP trial could occur. And as I told you, the amount of patients is so high that even if it's only 10 to 20% of the patients, it's a huge amount of patients that are ventilated in other modes than nasal CPAP every year. And the patients that are failing CPAP also have longer period of ventilation duration and longer PICU stay. So probably there are two different aspects that NAVA could help. First, we have to improve the performance of non-invasive ventilation in pediatric field. And second one will be about the improvement of ventilation even after intubation. Regarding the non-invasive ventilation period, there is not so much literature up to now in pediatric ventilation, but we recently completed this study, which was a feasibility study, so it was not really focused on bronchiolitis. We wanted to study a large representative cohort of patients. So there are various diagnoses, but 5 patients had bronchiolitis. And we were able to show a dramatic improvement of Synchrony in all the type of Synchrony, and you can see that the total time spent in asynchrony was decreased during NAVA from 30% of the time was spent in asynchrony during conventional ventilation in children, and in NAVA it was less than 10%. And if we focus at the 5 patients who had bronchiolitis, that you see exactly the same trend. So probably even if the study was not focused on bronchiolitis, it really helped, and this is the impression we have in clinical practice. And this study recently published by a team from Lyon in France confirmed this finding, and this was a study especially focused to the bronchiolitis population. These patients were relatively sick and randomized, studied after a failure of a nasal CPAP trial. And this was a crossover study, and you show a dramatic improvement in asynchrony index, ineffective effort, auto-triggering, and the double triggering were relatively equivalent or slightly increased in NAVA. So, of course, NAVA will improve markedly the Synchrony during non-invasive ventilation, especially during bronchiolitis. But does it translate into an improvement in intubation rates? It has not been confirmed, and we still have to study that. we only have the feeling that sometimes we are saving some intubation in some patients, but it's the clinical feelings that we have to confirm. Does it have an impact on the respiratory failure symptom? We also have to study that in more details. You can see here the evolution of the inspiratory activity of diaphragm in those 5 patients with bronchiolitis, and you see that during NAVA they tended to have a lower inspiratory EADI, so probably lower work of breathing and decreased respiratory rates, but this was a small number, so we still have to work on that aspect. Regarding the invasive ventilation, these studies, I think the improvement of Synchrony is not anymore a question. It's clear from many studies that NAVA markedly decreased the Synchrony, improved the Synchrony in general population, in pediatric patients, and this is just an illustration of the number of studies that have been conducted in PICU, and I've not detailed all the results, but as mentioned this morning, globally the time spent in asynchrony decreased from about 30% to 5%, or between 5 and 8% during NAVA. So it's not a question in general population in PICU. In bronchiolitis, there has been one study that has looked in detail at this population. This has been conducted by Karine Clément and published a few years ago, and she confirmed that during NAVA, the neural triggered breath had markedly decreased trigger delay, and the work of breathing down to trigger the breath was markedly decreased. I really also like this study, which is a very small study. It's only a case report. In fact, it's three cases, but it really reflects the clinical feeling that we have sometimes. So this is a study published by Jean-Michel Dillier from Nantes, and he showed that in very severe patients with bronchiolitis, sometimes you observe a dramatic response of this patient when you allow them to breathe in NAVA. And you see that in these two examples, the pressure were very high, about 30%, 35%, which is high for these kids. And when they are switched to NAVA, it's go down to less than 15, and this is the same in this patient, and you see a dramatic response also in FiO2. So these are cases report, but we have to we frequently observe such behavior. This topic has been placed in the hyperinflation or interesting PIP session, so I wanted just to discuss a bit about the distension, because hyperinflation is a real key component of bronchiolitis, and we could wonder if if placing these patients on NAVA will always improve this distension. And in fact, of course, we will improve the synchrony. I've shown that, and this is probably favorable for the hyperinflation, or at least for the consequences of hyperinflation. But then at the same time, we increase the support, and if the expiratory flow is markedly decreased, we could wonder if we won't increase even more the over distension. But in fact, we don't know exactly why the children with bronchiolitis have hyperinflation, and this has long been considered, and this is one thing that is frequently said, but it's probably part of the problem is that they have an increased expiratory resistance because of the edema or contraction of the small airways. But for a long time, it has also been suggested that it could also be an adaptive change, and the children, in fact, choose an increased lung volume to improve their respiratory mechanics, and this could be an adaptive response, a spontaneous adaptive response. And that leads me to this observation of, and I will speak about tonic activity. You've heard about that from this morning, that in infants it's very particular that at the end of inspiration, at the end of expiration, some part of the diaphragm remains active. This is a tonic activity, and this is because the children, the infants at least, try to actively elevate their lung volume to prevent the derecruitment. And we had shown that before in intubated infants, but in this study we confirmed that the tonic diaphragmatic activity remains present even after extubation. So the behavior is a bit different from rabbits who lose their tonic activity after extubation. In children, even at distance, the final recording was done when the patients were leaving the PICU, so they were not sick at this time. They have still some tonic activity. And an important findings of this study, I was relatively surprised of that finding, in fact, was that bronchiolitis diagnosis was the only independent factor associated with the high level of tonic activity. So it was a bit counterintuitive because these patients have an hyperinflation, and in fact their behavior is that they try to improve even more their lung volume. And you see that they have a tonic activity which is about 7 microvolts. So this part of the diaphragm never relaxes. It's continuously working. So this made me think that maybe the hypothesis that this is an adaptive change to improve the respiratory mechanism, and it's a voluntary adaptation of the patient. It may be important to consider, and the tonic activity is probably one of the mechanisms used by the infants to maintain this high level of lung distension. So this is interesting because this could explain why CPAP works so well, because you will favor the lung volume and probably you allow the diaphragm to rest a bit more during the expiration if you were able to decrease the tonic activity. We have to show that. We have not studied before after CPAP. And the other consequence is that if this is the case and this is a dynamic, an adaptive change, the risk to over-distance the lung by increasing the ventilation is not so high. So I think that I've shown that NAVA clearly improves Synchrony during non-invasive or invasive ventilation during bronchiolitis. It induces a marked decrease in ventilatory pressures in some cases, and we have the feeling that sometimes it saves some intubations, but it has to be confirmed, and the impact on the hyperinflation and the role of tonic diaphragmatic activity in these patients should also be studied. Thank you very much.